Okay, can everybody hear me?
Yes, we hear you.
All right. Good afternoon, everyone. My name is Abdul Tabara. I'm the only critical care anesthesia fellow. I've worked with a lot of you in the last few months. And today we're going to be talking about the use of neuromuscular blocking drugs in the management of ARDS. Unfortunately, I have no disclosures. So I was asked to do a pro-con debate or be part of a pro-con debate for this topic. I'm the only one presenting, so a pro-con debate to me, kind of in my head, looked like the scene from Me, Myself, and Irene. So I didn't really want to do that in front of all you guys. So basically what I'm going to do is I'll go over the use of neuromuscular blockers in ARDS, talk a little bit about the history of its use in ARDS, talk about the mechanism of neuromuscular blockade. We'll discuss the pros and the cons of ARDS in the management of use of paralysis in the management of ARDS, and we'll discuss some of the recent evidence surrounding the use of neuromuscular blockers in the treatment of ARDS. So ARDS, as you know, diffuse alveolar epithelial damage due to a dysregulated inflammatory response. It can be intrapulmonary or systemic in origin, results in refractory hypoxemia, decreased pulmonary compliance, and as you can see, typical chest X-ray in severe ARDS, bilateral pulmonary infiltrates. This is, of course, not due to cardiac in origin, nor due to fluid overload. So the numbers in the ARDS complicates about 10% of all ICU admissions. Mortality varies depending on the study that you're looking at, but anywhere between 35 and 46%. To date, there have been 7 major trials evaluating the use of neuromuscular blockers in the management of ARDS, and results to date have been mixed, especially with the release of the results of the ROSE trial last year. So these are the 7 major trials that have been done. Again, like I said, the major ones that were carried out were the Papazian trial, ACURASYS in 2010, and the ROSE trial last year. The other trials are much smaller in number in terms of their enrollment. So this is a look at the last 15 years or so, the incidence per 100,000 patients, and you can kind of see that 10 to 15 per 100,000 over the years, maybe a slight uptick. Mortality, however, thankfully has decreased from just under 60% from the late 90s to about the low to mid 40s in 2011. This is another larger meta-analysis from the early 80s to 2006. And again, you see the same trend. There's about a 33 decrease in mortality over the years. The Lung Safe trial was a large trial, 459 ICUs in 50 countries. One of the things they looked at was the mortality at 28 days. And again, whether it's mild, moderate, or severe ARDS, you see the same trend. So why do we kind of make a big deal of this? Why is it such a big deal? Because, you know, it's ARDS is, like we said, high morbidity, a good or high mortality, and it sounds good that we potentially have a drug that we can maybe use to treat this. There's some evidence out there that supports it. You know, us as practitioners, we want something that will work, and at the end of the day, right now, we may not know exactly what the best answer is. So this here just looks at the history of ARDS. So sorry, my mouse is acting up a little bit. In the mid-60s, ventilator-induced lung injury was first described in 1964. A few years later, ARDS in 1967 was then described. The theory of proning in the mid-70s wasn't really put into practice until later on, which we'll talk about a little bit. The mechanisms of ventilator-induced lung injury in the mid-80s were brought up. Permissive hypercapnia. so deviating from a normal CO2 level, was described in the early 90s, 1990. The first definition of ARDS in 1994 was released in Europe. Biotrauma in vivo was described in 1997, and we'll touch on that a little bit later on in the presentation. Lung protective ventilation, lung protective strategies, low tidal volume, late 90s, the early 2000s. The first big trial that we'll talk about, the ACURASYS trial, was in 2010. Like we said, prone positioning was described back in the mid-70s, but the first, or a major trial in 2013, the PROCEVA trial, and then the Berlin definition in 2012. And then driving pressure described in 2015. So looking at what other practitioners are doing, this was a multi-center survey sent out from Cleveland Clinic. It was sent out to a mix of practitioners, so MDs, fellows, mid-levels, and pharmacists. And the question was, about 70–80% of the respondents thought that neuromuscular blocking drugs were effective. A little bit less, between 40 and 50% of the patients thought that neuromuscular blockers are safe. Somewhere around the 10–20% range thought that neuromuscular blockers should be initiated in all patients with ARDS. And between 40 and 50% or so of respondents thought that they should be initiated in severe ARDS. This stepwise approach to the treatment of ARDS was released by the same investigators of the ARDS trials. And again, they start off with lung protective ventilation, increasing PEEP with decreasing P to F ratios. When P to F goes below 150, that's when they describe prone positioning and neuromuscular blockers. And then in the extreme or severe, really severe cases of ARDS with P to Fs of less than 80, they suggest considering VV ECMO. So a little bit about what happens when we paralyze our patients. So normally, action potential will arrive, leading to vesicle fusion at the neuromuscular end plate right here, releasing neurotransmitter, which is acetylcholine, into the synaptic cleft. Acetylcholine then binds to its receptor. So the receptor has 5 subunits, 2 alpha subunits, a beta, delta, and a gamma. So acetylcholine binds to the alpha receptors, and then that way the muscle contraction can occur. Now, neuromuscular antagonism, and this applies to non-depolarizing neuromuscular blockers. They are competitive antagonists at the receptor. So once they bind here, they block further acetylcholine binding, and what you'll get is classic paralysis. The types of non-depolarizing neuromuscular blockers, we have 2 groups, the aminosteroids and the benzalkonium. The aminosteroids, pancuronium, which is a longer acting drug, and vecuronium and rocuronium. We commonly use these as anesthesiologists in the OR. And then the benzalkoniums, those are the atracurium and cisatracurium. Cisatracurium we use also in the OR occasionally, as well as in the ICUs, and we'll talk about that. So it's really important to understand what paralytics do and what they don't do. So their name, they paralyze. What they don't do, though, is they do not provide any type of analgesia, and they do not provide any type of amnesia. This is really important, and we'll talk about that in a bit. So these are most of the neuromuscular blocking agents that we have. Like I said, they're divided into depolarizing and non-depolarizing groups. The depolarizing agent, sole agent, is acetylcholine, which has no role in the management of ARDS. So we won't be talking about that. Cisatracurium, the most commonly used agent, onset is within a few minutes, 3 to 5 minutes. The reason why it's favored to be used in the ICU is that it does not depend on renal or hepatic elimination of metabolism. Pancuronium was the drug of choice that preceded cisatracurium. The duration of action was much longer. So things that we need to think about when using neuromuscular blockers in the ICU. There are some things that will increase this duration, some things that will decrease. Antiarrhythmics, aminoglycosides, MAG, lithium, hypokalemia, acidosis, and hypothermia will all increase the duration of action. Steroids, calcium, and anticonvulsants like phenytoin will decrease this duration. We have a way of monitoring neuromuscular blockade. We do this in the OR frequently, and we can do it in ICU as well. This is a peripheral nerve stimulator here, which is attached to or will monitor the ulnar nerve. So stimulation is then followed by assessing the response. The ulnar nerve is the recommended site of monitoring. It's a superficial nerve, and you're able to see the reaction, or the response, which is contraction of the adductor pollicis longus. So 4 supramaximal stimuli are given half a second apart, and we look at the ratio between the 4th and the 1st twitch, or the response that you'll see. And that's measured. If you see 4 twitches, then 0 to 75% of the receptors are blocked. 3 twitches are seen, then at least 75% of the receptors are blocked. If 2 twitches are seen, then you have 80% blockade. If you have 1 twitch that's seen, then at least 90%, and no twitches are seen, all of your receptors are blocked. In the ICU, we don't need patients to be completely paralyzed with 0 out of 4 twitches. We'll talk about this, but we need them to just not be fighting or dysynchronous with the vent. So what are the indications for neuromuscular blocking drugs in the ICU? ARDS is a big one. Intubation, increased ICP, status asthmaticus, increased abdominal pressure, or post-cardiac arrest. Everything's going to have pros and cons. Cons with, like any medication, is going to be anaphylaxis. A big thing that we'll talk about in a little bit is insufficient sedation or recall, increased atelectasis, or maybe increased ICU acquired weakness, corticosteroids and hyperglycemia. We'll talk about that as well. The pros of using paralytics and ARDS: decreasing mortality, increasing your ventilator free days, increasing your ICU free days, increasing oxygenation, and decreasing barotrauma, and then decreasing your ventilator-induced lung injuries. So we talked about this, the big things being reducing your dysynchrony with the vent, increasing survival, less biotrauma. So this illustration here depicts a patient, what could happen in a patient before they're paralyzed. So if they're becoming dysynchronous with the vent, increasing pressures are generated into the alveolus, leading to increased pulmonary blood flow and increasing your capillary permeability. All this is shown to increase mediator release, interleukin 8, interleukin 6, tumor necrosis factor alpha. And all this with your increased permeability of your capillary here will lead to that leaching into the systemic circulation and leading to distant organ damage. Now, on the other hand, in the patient who is paralyzed or not dysynchronous or synchronous with the vent, all this stuff doesn't really happen. So you have less injury, normal blood flow to your alveolus, the permeability is maintained, and you don't have these release of inflammatory mediators. So we'll talk about a lot of data. There's going to be we'll go through a lot of the data that's been mentioned in the literature. So decreased oxygen utilization. This was a prospective trial where they put 8 patients on varying modes of ventilation. So they measured the oxygen utilization in patients who were on CPAP, in patients who were on assist control ventilation, and patients who were on assist control with mechanical with muscle relaxation. So in all but one of the patients, you notice that going from CPAP to assist control to muscle relaxation, decreasing their VO2. And it's been shown to be about 20% decrease. These results were able to be replicated. Again, patients at their baseline, and then after paralysis, just looking at the slope of the line, it's easy to see that their oxygen consumption in mils per minute per meter squared decreased. Using muscle paralysis has also been shown to increase the PDEF ratio in ARDS. So these patients, this was a prospective trial, they were paralyzed for 48 hours, after which paralysis was stopped. And you'll see there's a significant increase in the P to F ratio. Despite having stopped the paralytic at 48 hours, that increase or that change, that difference in P to F ratio was maintained, and it did maintain statistical significance. This study was also replicated, and it showed the exact same thing. 48 hours of paralysis, and that increase in P to F was maintained up until 120 hours, which is when they stopped collecting data. So the Papazian trial, this was the big ACURASYS trial in 2010, they also showed a significant reduction in the number of pneumothoraces. This was all days reached significance, but it was most profound in the first 48 hours after inclusion. The probability of being liberated from the ventilator also increased with paralysis in the patients who were paralyzed. This did not reach statistical significance, however. As you'll see here, this was also from the Papazian trial in 2010. The increased survival, decreased mortality was higher in the cis-atracurium group. However, you'll notice that the first 18 days of data collected, these graphs were essentially, or these curves were essentially superimposed. And you didn't really see a difference or a separation of these curves until after day 18. The reason for this is not quite known. After post-hoc analysis for this, they realized that the patients that this decrease in mortality was only in patients who had a P to F ratio of less than 120. If you look at patients who had a P to F of over 120, their trajectories were essentially identical. The transpulmonary pressure is an indicator of potential stress on the lung parenchyma, which we think leads to ventilator-induced lung injury, ARDS. It's thought to provide a more accurate assessment of stress versus just peak pressures or plateau pressure. This was a study done in 2017 and looking at pre-neuromuscular blocker versus post-neuromuscular blocker. And they noticed two big changes. Decreases in the swings of PEEP required. This leveled out after neuromuscular blockade. And the peak pressures were also decreased compared to prior. The amount of PEEP used in these patients was also less. This was statistically significant. Again, these patients were only paralyzed for 48 hours, and those differences were noted throughout the time. Plateau pressures were a little bit different. For some reason, during the first 72 hours, these curves kind of flip-flopped, but after 72 hours through the end of data collection of 120 hours, there was a difference in plateau pressures, and that was reverse triggering is a kind of breath stacking that was first described in 2013. And this is in response to, or it's an inspiration in response to the ventilator providing a breath to the patient. It's described in heavily sedated patients. Actually, it's described more so in heavily patients than in patients who are lightly sedated. And the only way to reliably get rid of this reflex is with paralysis. So what this shows here, so the pressure, the airway pressure here, and this is a ventilator-induced or a ventilator-initiated breath that's given to the patient. The patient, during or before expiration, triggers another breath, another full tidal volume breath, and you'll see that there's increases in air pressure and airway pressure with this breath. We can tell here this is a measurement of the electrical activity of the diaphragm, and during this first ventilator delivered breath, the patient does not initiate. However, with the second breath, electrical activity goes up, and we know that this is the patient that's delivering this breath, or that's taking this breath. Biotrauma and ARDS, there's been some work on this recently, and they're looking at the mediators that are released during injurious ventilator strategies. The nicotinic acetylcholine receptors are thought to play a pro-inflammatory role in ventilator-induced lung injury. So a lot of these studies were done in lab rats, not those lab rats. So in these lab rats, and what they did was they had their experiments were to titrate induced lung injury and titrate to a P-def ratio of less than 250. And so they had 4 groups of rats. The first group, they were not given paralytic, and they were allowed to have asynchronous ventilation. The second group were also not given paralytic. However, they were synchronous with the vent, and this was done by titrating their level of sedation. The third group received cis-epicurium, and the fourth group got pancuronium. And then what they did was they looked at blood and bronchoalveolar BAL samples, and they measured interleukin-6, interleukin-8, and tumor necrosis factor alpha. So what they found in the cis-epicurium and the pancuronium groups, so these samples are in the BAL fluid, they found significantly lower levels of tumor necrosis factor alpha. They also found in plasma significantly lower levels of tumor necrosis alpha in the cis group and the pancuronium group. These did not reach, they were about the same in the BAL fluid for interleukin-6. However, they did notice they did measure significantly lower levels of interleukin-6 in plasma. We talked about this, and then they also noted this is only for cis-epicurium, interleukin-8 levels were also lower. So this kind of may be an explanation for why we have distant organ injury in patients with ARDS. The nicotinic acetylcholine receptor has also been, or blockade of that receptor has been associated with decreased calpain-1 activation. So calpain-1 activation, what that does is upregulates pro-inflammatory cytokines, increases adhesion molecules, and allows for inflammatory cell migration, and increases chemotaxis. Just a side note about Sugammadex. This is one of this is a relatively newer drug that we think about when we're using non-depolarizing muscular blockers. So this has kind of been a game changer for anesthesiologists, especially when we administer paralytics, in that it's a reversal agent. So as you can see, it forms a complex where it encapsulates the drug and renders it inactive, basically, and unable to bind to the receptor. This is just important that if we had to reverse a drug, we have an option. And this is only used, though, in the immunosteroid group, so vecuronium, rocuronium, for example. So in summary, our pros, we have multiple trials that show the effects of paralytics in the treatment of moderate to severe ARDS. So increased oxygenation, decreased oxygen consumption, increased survival, decreasing inflammation resulting from ventilator-associated injury, and can help prevent injurious ventilator maneuvers. So we talked about the advantages, and of course there are going to be some disadvantages. ICU myopathy, ocular injuries, adverse cardiovascular events, impairment of our natural protective reflexes, and nerve compression injuries. So ICU myopathies were first described in the early 80s. Glucocorticoids have been shown to have a catabolic effect on skeletal muscle. We'll talk about the direct link with neuromuscular blockers and myopathy. Most of this evidence, though, does point to a combination of steroids and neuromuscular blockade. Risk factors have been shown to be female sex, multiple organ dysfunction, duration of mechanical ventilation, and administration of corticosteroids. This is a little bit of a busy, and I hope you guys can see this, but factors that will also contribute to ICU-associated weakness. So multiple organ failure and these inflammatory mediators that we talked about, hyperglycemia and insulin resistance, steroids, and neuromuscular blockers. The Vandenberg trial back in 2001 showed the effect of hyperglycemia, and they found statistical significance for increased evidence of, or EMG evidence of critical illness myopathy. In Lancet Neurology in 2011, 2 types of ICU-related weakness were described. Both of these did have good prognosis. The first one is a transient neuromuscular blockade, which is common with neuromuscular blocking agents. Limbs are flaccid and there's respiratory weakness. CK, if it were to be sent off, would be normal. and muscle biopsy, which is rarely performed in these cases, but if it were to be performed, it would be normal. And the prognosis is good. The second one is critical illness myopathy or thick filament myopathy, more common with steroids and paralytics, as well as in sepsis. Again, the presentation is the same, so flaccid limbs and respiratory weakness. CK may be mildly elevated. And there's loss of myosin of thick filaments, but again, the prognosis remains good. If we were to look under a microscope, this top left slide here shows normal muscle fibers. This is on a TB stain. Now, if you look at the bottom left, these are some normal muscle fibers interspersed with some atrophic and poorly staining fibers. And the same with an H&E stain on the right, same thing with some normal and some atrophic fibers. There may be a modest association between neuromuscular blockers and neuromuscular dysfunction and critical illness. However, the incidence was higher in patients who were septic and received neuromuscular blockers. In rats, steroidal compounds were found to be related more with an ICU myopathy. So those steroidal compounds are VEC, ROC, and pancuronium. In the ICU, again, we tend to use cisatracurium more frequently than these other agents. The ROSE trial also showed us an increase in serious cardiovascular events. So in the cisatracurium group versus the control group, 14 events versus 4, and this was statistically significant. We'll talk about this a little bit later. Ocular surface disorders, so conjunctivitis or exposure keratitis, corneal erosions, occurs in a not insignificant number of patients, 20 to 60% of patients that are heavily sedated or paralyzed. Because eyelid closure is an active process, it requires contraction of the orbicularis oculi, as well as inhibition of levator palpebris superioris, which our paralytic would take care of. However, so this needs, like I said, it's an active process. This can be dealt with paying attention to bedside care, making sure the eyes remain closed, and using lubricating drops. DVT, so this was a large prospective study looking at the incidence of DVT in the ICU. 2 factors were statistically significantly found to be associated. That was the length of mechanical ventilation in days, as well as neuromuscular blockade. This is a really, really important topic. So awareness while patients are paralyzed. This should be a never event. It's traumatizing to the patient, and we'll talk about that in a little bit. And it can result in a PTSD-like picture. So like we said, neuromuscular blockers have no sedating properties whatsoever. So sedation and analgesia must be ensured prior to paralyzing patients. This is a prospective study this is a retrospective study looking at patients that complained of awareness while they were paralyzed. And you'll notice that all of them did have some form of amnestic, some sort of sedative that was ordered. Despite all this, patients did complain of awareness. Common complaints were feelings of worry or feelings of nervousness. At the same time, as they're able to tell what's going on, when practitioners talk to the patients and they reassure them or explain things, even though patients aren't able to respond because they're paralyzed, they can remember all of this stuff as well. Complaint or experiences that patients have, they may have an experience of being gone or being dead and then alive, feel like they were dead, that they were never going to wake up. So this is really, really important, and really important to ensure that patients are adequately sedated before we paralyze them. And it can happen even though they're on really high doses of sedatives and analgesics. Moving forward, and we've had this protocol for a while, but if there's any doubt or you're unsure of how to start, there is a tier 1 protocol on 1 Henry that you can follow to make sure that your patients are adequately sedated and adequately have adequate analgesia prior to placing them under paralytic. Protective reflexes are impaired. So again, the same with the eye closure and eye lesions, that attention needs to be paid to the bedside care, regular suctioning and whatnot. So anaphylaxis with any drug is a risk. We use cisatracurium mainly, and most of the studies have been done under cisatracurium, and it does have the lowest risk of anaphylaxis. If we were to look at the cross-reactivity across the board, for patients who have had anaphylactic reactions to neuromuscular blocking drugs, you'll notice that cisatracurium, which is here in the red, is quite low across the board. It does have the highest cross-reactivity with atracurium, as they are in the same group. So now I'll take a little bit of time to talk about the two major trials, the two bigger trials that were done looking at neuromuscular blockers. The first one is the ACURASYS trial done in 2010. So this was the first large trial to look at neuromuscular blockers. It was a multi-center, double-blinded study. They enrolled 340 patients with moderate to severe ARDS, a P-to-F ratio of less than 150 for less than 48 hours. Patients were paralyzed with cisatracurium and deeply sedated for 48 hours. And then the control group was deep sedation only. They had a low PEEP strategy, so they only used a PEEP of 5. The primary outcome that they were looking at was 90-day mortality. Secondary outcomes were 28-day mortality, days spent outside of the ICU, organ failure-free days, barotrauma, ICU-acquired paresis, vent-free days, and ICU discharge. During the study, or while patients were paralyzed, they did not measure or they did not assess neuromuscular blockade. They admitted, and it was an underpowered study. 10% of patients were excluded for other reasons, which are unknown. And when patients were dysynchronous with the vent, they did not address this. So when you have patients who are paralyzed versus patients who are not paralyzed, it's a little hard to truly double-blind the study because any patient that moves or is dysynchronous with the vent, they're probably in the non-paralyzed group. We mentioned how that there was a positive effect in decreasing mortality in patients who had a P-to-F ratio of less than 120. And this was, again, noticed only after 18 days. Patients with a P-to-F ratio of more than 120, however, they performed the same. The ROSE trial was the reevaluation of neuromuscular blocking agents in moderate to severe ARDS as well. They compared patients who were paralyzed with cisatracurium and deeply sedated for 40 hours versus light sedation only. So it was slightly different than the ACURASYS trial. Again, it was a multi-center randomized trial, 48 hospitals in the US, a little over 1,000 patients. They used high PEEP, which was a PEEP of 8, and they stopped the trial early for futility. Their primary outcome that was measured was in-hospital death from any cause by day 90. And their secondary outcomes were in-hospital death by day 28, days free of ventilation at day 28, days not in the ICU at day 28, and days not in the hospital at day 28. So their data, so if you look at this upper curve, these are the patients who survived to hospital discharge, and you'll see the intervention and the control groups had essentially identical courses. And that's the same for patients that were discharged home. Same, the intervention group and the control group had essentially overlapping curves. So the differences between the two trials, because some people like to compare them as they're the two biggest trials. So the criteria were for admitting the patients were the same, which was a P-to-F of less than 150. The PEEP was different in both trials. One difference was that patients in the ROSE trial were the median time for admission from ARDS diagnosis to admission to the trial was only 8 hours, while it was 16 hours in the ACURASYS trial. And that could have resulted in patients who would have been enrolled into for example, the ACURASYS trial, but didn't make it because they may have expired, for example, before that. The controls were different. So both received cisatracurium, or both intervention groups received cisatracurium and deep sedation, while the control group only received light sedation in ROSE and deep sedation in ACURASYS. The PEEP, like we said, was different. In terms of serious or adverse events, pneumothorax was more frequent in the control group in ACURASYS. ROSE did not find a difference in overall barotrauma. However, there were more cardiovascular events in Rose. So again, this is cardiovascular events as a whole reached statistical significance. These were serious cardiac events. So complete AV block or AFib with RVR, cardiac arrest 3 times as more likely in the cisatricurium group, MI, torsades de pointe. So some people, again, like we were saying, do have compared the 2 trials, but it's a little bit of an unfair comparison because the groups were a little bit different. These trials were performed 10 years apart, but it's tempting to compare them because they are the 2 largest trials that we've had. Because the patients in the control group in ACURASYS were deeply sedated, so was reverse triggering an issue at that point? Is that why that group had worse outcomes? Perhaps a subgroup analysis looking at the breakdown of different patients in each group, whether the underlying cause was sepsis or shock or some other form, if that would have shown a difference. In 2017, so this was prior to Rose, ATS, SECM, and the European Society of Intensive Care Medicine, they released their recommendations. And to quote, significant advances have been made in the ventilatory management of ARDS in the last few decades. It is expected that future iterations of the guideline will address questions related to pharmacologic therapies to facilitate mechanical ventilation, for example, neuromuscular blockade. So where do we go from here? An editorial in the New England Journal of Medicine, the title sums it up. Early paralytic agents for ARDS? Yes, no, and sometimes. To conclude, neuromuscular blockers have shown some benefit in severe ARDS, increasing oxygenation and decreasing lung injury from vent dysynchrony, decreasing inflammatory mediator release. Although we did see that decreased inflammatory release was from in rat modeling, but we have yet to see any kind of that put into practice. There's a risk of critical illness myopathy, but how severe? Because the ones that we've seen do have good outcomes. There is a risk of barotrauma, and there is a statistically significant increase in the risk of cardiovascular events. So maybe it's the deep sedation that's associated with adverse patient ventilator interactions, which are less likely to occur in the setting of light sedation or neuromuscular blockade. In the end, I think that this stepwise management does do a good job of summarizing an approach to treatment of ARDS. The paralytics in ARDS should be tailored to specific underlying diseases or the injury mechanism, rather than being uniformly applied or not applied to all patients. And there is sometimes a role in for paralytic in the management of ARDS. Thank you. That's all I've got. I can provide references for anybody that would like to read a lot more about this. If anybody has any questions or comments, please feel free. All right. Okay. All right. Well, thank you all for bearing with me. I hope you all learned something. And I'm available if anybody has any questions offline. Thank you all.